Hello, everyone, and welcome to our question lab. We're happy to have you here. And today we'll be talking about musculoskeletal. We've got 4 good questions for you guys, and we hope that'll be a great learning experience. If you guys look on the right side in your control panel for GoToWebinar, you will see a question box, and we have some wonderful panelists here that are here to help answer those questions for you. I'll introduce them briefly, starting off with our first panelist, who is Kasha, one of our RX coaches. Kasha.
Good evening, everybody. It's very nice to be here. I'm one of the RX coaches. I've been working with RX Coach for just about 6 months now, mostly working with students studying and practicing for in preparation for their Step 1 and COMLEX Level 1, but also with students who are working towards Step 2 and for some of their class exams as well. It's really my pleasure to work with students who are working towards their top goal and achieving their dreams. So I'll turn it over to the next person.
Excellent. We're happy to have you here. Along with Kasha, we also have Kate who will be answering questions, and Mr. Jeff Downing, who you will meet in just a second. Jeff, do you want to introduce yourself briefly?
Well, sure, everyone. I'm Jeff Downing. I am the Director of Product here at ScholarRx and USMLE-Rx, and happy to be here working with all of you to help you up your game. We've been doing this now for 4 months. It's been a great experience for everybody involved, especially from our end, and we've gotten a lot of great feedback from you guys. So we're hoping that tonight is another substantive and helpful question lab.
Excellent. Thank you. And we're happy to have Jeff here with us, and we're happy to have you here. You've had a chance to meet our panelists. I'll introduce myself. My name is Sean. I've been in USMLE and test prep for about 10 years and with RX Coach for a little over 1.5 years, working with students to help them accomplish their goals. And so we'll talk about RX Coach here in a little bit, but you've had a chance to meet us. We'd like to get to know you. So tell us, who are you? Are you a MD US student? Are you a DO US Canadian student? Let us know who you are. So we'll give you guys a couple of seconds to respond, and then we will move on and kick off our webinar today and do 4 questions on musculoskeletal. Excellent. We'll give you guys a couple more seconds to respond. This is the same format you will see for all of our questions this evening, and you'll have a chance to submit your responses. And then, of course, we'll go over the correct and incorrect responses. Last week, we had some really challenging questions. I think on one of them, only 7% of the crowd got it right. So we're going to go a little bit easier on you tonight, but not too easy. But we hope it'll be a pleasant learning experience for all of you, and we appreciate you attending. We do these webinars every Tuesday at 6 p.m. And so we're glad to have you here. Excellent. Looks like 71% of you guys are international medical students or graduates, and 23% of you guys are US Canadian born international medical students or graduates. So a heavy IMG crowd, and we're happy to have all of you here. Let me ask you guys this. I know most of you guys are studying for Step 1. We'd like to know, when are you planning on taking Step 1? So we'll give you guys a couple more seconds to respond and let us know when you plan to take your exam. Excellent. I see the responses coming in. We'll give you guys a few more seconds. As always, we will have a raffle at the end of the evening, so make sure you stick around because you must be present to win, okay? You must be present to win. And just so you guys know, next week we're going to be doing a question lab on general path. So make sure you tune in Tuesday at 6 p.m. for our question lab on general pathology. All right. And it looks like a lot of you guys are taking it here later this year. So about half of you guys, almost 60% of you guys will be taking it at some point between now and the new year. So we're happy you're here, and we wish you the best of luck on your exam. And we'll talk about certain things that you can do to help improve your score and some resources which are available to you here as the evening progresses. Like I mentioned, I'm with RX Coach, as is Kasha. RX Coach is our new one-on-one tutoring program. We'll talk more about that later as well. But for now, I want you guys to know that the methodology we'll be using in tonight's question lab as we approach these questions will be the same methodology that we use in RX Coach. So without much further ado, I want to hand it off to Mr. Jeffrey Downing so we can get rocking and rolling.
Excellent. Let's start with question number one. Question number one tonight. And as we launch this, a couple things you're going to note. One is that you don't see the answer options yet. And we do this by design. We cover up those answer choices so we don't begin to artificially guide your thinking, nor do we want to panic you by offering up answer choices that you may not be familiar with. Sometimes students will see something that that they know they haven't studied or is unfamiliar to them. It causes a little bit of anxiety. So this is how we like to we instruct you to start it off, covering up those answer choices, and then starting off with the lead-in, which is the question there at the bottom. Which of the following complications is most commonly associated with this woman's condition? And from there, then we can read the vignette. A 72-year-old woman presents to her primary care physician with a new onset headache on the right side of her head, along with jaw pain on chewing. She is also experiencing blurry vision in her right eye. On physical examination, her temperature is 100.4 Fahrenheit. Blood pressure is 130/80. Visual acuity testing confirms a loss of sharpness of vision in the right eye. And we also list out the lab studies. So take a look at those lab findings, and we go back to our question. Which of the following complications is most commonly associated with this woman's condition? So we'll give you a couple of seconds. Sean, how do you tackle this one?
Excellent. Thank you so much, Jeff. You know, this is a great question. And before we get into answer choices, I want to ask you guys if you think this is a one-step question, a two-step question, or a three-step question, right? So an example of a one-step question could be where they ask you the diagnosis. A two-step question could be where they ask you, what is a treatment for a diagnosis? And a three-step question, an example of that could be where they ask you, what is the mechanism of action for a treatment for a diagnosis? So with those examples in mind, please let us know in the question box how many steps you think this question will require. And while you're at it, if you think you know what the diagnosis is, feel free to let us know what you think the diagnosis is. And we'll go over that when we go over the answer choices and the correct and incorrect answers. So we'll give you guys a couple of seconds to submit your responses here. Perfect, and I see a lot of students are on the right track. So let's go ahead and uncover these answer choices. This is probably a two-step question, right? So first we need to figure out what this patient has and then what else could be associated with it. And it's important to keep that clear because this is not asking us for the diagnosis. It's asking us for a complication associated with that diagnosis. So our first step is to know the diagnosis. Our second step is to discover and figure out what that complication could be. So answer choice E, muscle weakness and skin rash. D, morning stiffness in the shoulders. C, joint pain and swelling. B, fatigue and soft tissue pain. And A, bloody diarrhea and abdominal pain. So I'm going to open up the poll and give you guys a few seconds to submit your responses. A lot of you guys already nailed the diagnosis, so good job to those of you who got it. I'm not going to give you that answer just yet, but let's see what you guys come up with, and then we will go over the diagnosis, both of the steps, and the incorrect and correct answer choices. So if for some reason you're confused, you're not sure what the answer is, feel free to take your best guess. Remember, on the test, you're not going to be penalized for guessing. You only get points for correct answers. So never leave a question blank on test day. Looks like a lot of you guys are on the right track. We're off to a good start this evening. We'll give you guys a few more seconds to submit your responses, and then we will go over the correct and incorrect choices. It's important to keep in mind that when you're doing practice questions, make sure you go over the correct and incorrect choices to make sure you got the right answer for the right reason, and that you still learn from the incorrect choices as well, because these are great learning points in these explanations as you're practicing. All right, let's see how you guys did. Looks like 34% of you guys picked D, morning stiffness in the shoulders, and 27% of you guys picked answer choice C, which is joint pain and swelling. So let's see what the correct answer is. And the correct answer is D, morning stiffness in the shoulders. And 34% of you guys got it right. So very well done. So let's go ahead and talk about this question and why that is the correct answer. So a couple things to notice right away. And one of the keys, especially to answering this question, is going to be realizing these lab values and how important they are. They immediately tell us that we have elevated ESR and C-reactive protein. And we'll get to what those lab values mean here in just a second. But let's talk about this patient's symptoms. So we know that this patient has a headache on the right side of her head, jaw pain on chewing, and blurry vision in her right eye, along with a loss of sharpness of vision in the right eye. So these are kind of the main clues in our question, along with those lab values. So if you look at these lab values, you're going to see that she has increased platelets, increased ESR, and increased C-reactive protein. Now remember, C-reactive protein is indicative of inflammation. So this helps us get to the fact that this is an inflammatory vasculitis and is a great clue. ESR is also a sign of inflammation in the blood. So these two lab values are very, very important clues. Now, they also mention that this patient had a loss of sharpness of vision in the right eye. They're probably alluding to central retinal artery occlusion. All of these things are characteristic of what many of you guys mentioned earlier, which is temporal arteritis or giant cell arteritis, okay? So as you can see here, it's a unilateral headache, okay? Jaw claudication, okay? And we also have these visual problems, and it can lead to irreversible blindness due to ophthalmic artery occlusion, okay? So in summary, we have the symptoms of a one-sided headache, jaw claudication, possible central retinal artery occlusion, along with elevated ESR, CRP, and platelets, okay? So now we know that this patient has temporal arteritis. That's our first step. Now we have to go one more step to see a complication that this patient may also have. And that complication is polymyalgia rheumatica. And it is a related inflammatory process that often coexists with temporal arteritis. And going back here, you can see here that it is associated with polymyalgia rheumatica, okay? So in polymyalgia rheumatica, patients will experience morning stiffness in the shoulders and in the hips. And both of these conditions can actually be treated with corticosteroids, okay? Excellent. So we know that the correct answer is D. We talked about why it's D. Let's talk about why the other answer choices are incorrect, okay? So we see here muscle weakness and skin rash, and that's going to be characteristic of dermatomyositis. And in this condition, muscle weakness is going to occur, but it's not going to happen in the temporal arteries. And you can have fatigue and soft tissue pain, but you're typically not going to see that here as well. You'll see more of that in fibromyalgia. So fatigue and soft tissue pain, answer choice B, you're probably going to see more of that in a different condition. But let's go back to answer choice E for a moment. So dermatomyositis is an inflammatory disease of the muscles and the skin. And what happens here in this condition, and where you really see it, is patients that have cancer, and patients that develop this condition should really be screened for malignancies. But we don't see muscle weakness, and we definitely don't see the characteristic skin rashes in this patient. So that's going to help us rule out answer choice E. Answer choice D, we talked about, that is the correct answer. Answer choice C, we're talking here about joint pain and swelling, and we're going to see joint pain and swelling characteristically with rheumatoid arthritis, and you'll see the swelling and joint pain, especially in the fingers, the hands, the knees, and the feet. And patients with rheumatoid arthritis do have this pain and swelling, but it's usually worse in the mornings. But we don't have that in this patient. It would not explain the headache and the loss of vision, and that headache and loss of vision are not associated with rheumatoid arthritis. So we're going to use those two clues to rule out rheumatoid arthritis. Answer choice B, that's referring to fibromyalgia, and that, as you guys know, is idiopathic, and it's a chronic condition of diffuse musculoskeletal pain that usually manifests in young to middle-aged females. And patients will often complain of stiffness or fatigue, cognitive disturbance. And once again, the two clues that will help rule this out is that in fibromyalgia, you will not really see loss of vision and headache. So once again, those two symptoms help you rule out another answer choice. And some of you guys may have seen the ESR and CRP and realize that it's related to inflammation, but not realize what type of inflammation. And if you didn't realize that, you may have picked answer choice A, which is an inflammatory bowel disease that leads to abdominal pain and bloody diarrhea. But once again, not associated with headaches or loss of vision, and you're not usually going to see these lab values in a patient with with ulcerative colitis. You'll see that in people that have temporal arteritis. So the take-home point is, anytime you guys see a vignette that talks about one-sided headache and jaw claudication, immediately add temporal arteritis to your list of differentials, because 9 out of 10 times that's going to steer you in the right direction. So once we figured out it's temporal arteritis, we realized that the complication could be morning stiffness, and answer choice D was the correct answer. And with that, I'll kick it back off to Jeff.
Excellent, Sean, and that's good. Good warm-up question for today. And I was kind of watching the stats as everyone was answering, and for a while there, it was probably about 50-51% that were hitting, choice D. And I think some of you that were a little bit unsure, kind of waiting till the end, brought that number down a bit. But overall, good way to start it. So let's take a look at question number 2. And again, we will start with the lead in there at the bottom, which is the function of which of the following muscles is most likely affected by this patient's injuries. So let's read the story. A 20-year-old woman presents to the emergency department after an attempt to commit suicide by cutting her wrists. She has never tried to cut herself in the past and currently denies active suicidal or homicidal ideation. All of her vital signs are within normal limits. Physical examination reveals several superficial lacerations on the medial side of the ventral left wrist. She has some sensory loss over the left 5th digit. After obtaining relevant laboratory test results, the resident places calls for psychiatric and orthopedic consults. So again, the question, the function of which of the following muscles is most likely affected by this patient's injuries? Where do we take this one, Sean?
Well, thank you very much, Jeff. So we're going to take this one a different direction, okay? So I normally ask you guys how many steps you think this question will require. And I do want you to think about that. But we're talking about somebody trying to cut their wrist. And whenever we see that, we immediately start thinking of probably 2 nerves will come to mind. Tell us what 2 nerves are coming to mind when you think of somebody or see somebody that is trying or has, in fact, cut their wrist. We'll give you guys a second to let us know what nerves could be involved. So we see some people saying median and ulnar and radial, and you guys are on the right track, okay? So very well done. So now with that clue, I'm going to go ahead and uncover the answer choices, and let's read these choices from E to A. And the reason why we read these answer choices from E to A is to make sure that you get through all of the answer choices. It forces you to look at all of them and prevents you from prematurely picking an answer without seeing the other choices, okay? So E, opponens pollicis. D, lumbricals. C, extensor pollicis brevis. B, adductor pollicis. And A, abductor pollicis brevis. And with that, I'll open up the poll and give you guys a few seconds to answer this question, and then we will go over the incorrect and correct answer choices. Give you guys a few more seconds to respond. So last week in the question lab, we actually had a student ask us if we could do an anatomy question with MSK. So your wish has been granted, and here you go. We'll give you guys a few more seconds to respond. I see you guys are pretty split with all these answer choices, which probably means you haven't reviewed anatomy in a while, but don't worry, we're gonna walk you through this here together. So take your time, take a few more seconds, give us your best shot, give us your best guess if you don't know what the answer is, and we will learn this material together here in just a moment. All right, let's see how you guys did. Looks like 24% of you guys was tied, okay? 24% of you guys picked E, opponens pollicis, and 24% of you guys picked B, adductor pollicis. And the correct answer is B, adductor pollicis, which 24% of you guys got it right. So well done for those of you who got it. Good job with your anatomy knowledge from back probably from semester 1 of medical school. All right, but just because you learned it a long time ago doesn't mean you don't have to know it now, okay? So let's go ahead and talk about why that's the correct answer and why the other ones are incorrect. So we see here that this patient is coming to the ER, okay, after an attempt to commit suicide by cutting her wrists. Now, if you look here, there's some very important clues, and the important clues here are the directional ones. We know it's superficial. It's on the medial side of the ventral left wrist, okay? Of the ventral left wrist, and she has some sensory loss over the left fifth digit. So knowing exactly where that laceration was is going to help us identify what has been injured, so we can see then what will be affected, right? So we have to see what nerve has been injured and then what will be affected as a result of that. So we have to break it up into those two steps. So a lot of you guys said median nerve and some of you guys said ulnar nerve. And you're on the right track. Now, the median nerve is the most commonly injured nerve in patients with wrist lacerations. But remember, it runs deep in the carpal tunnel, and it's not usually affected by superficial lacerations, which is what happened in this patient. Rather, in this patient, because of that superficial laceration, because it gave us that clue, okay, it's going to point to an ulnar nerve injury rather than a median nerve injury, okay? So if you slash the wrist on the ventromedial aspect of the arm, you may injure the ulnar artery and the ulnar nerve. And if you look here, the ulnar nerve, okay, provides sensation over the medial 1.5 digits, okay? Over the medial 1.5 digits, the hypothenar eminence, as well as the intrinsic muscles of the hand that are supplied by the deep motor branch. Now, patients with an ulnar nerve lesion in the wrist may have what we call ulnar claw on digit extension, ulnar claw hand on digit extension. Now, one thing to keep in mind here is that the adductor pollicis muscle has an oblique and transverse head, and both of those are innervated by the deep branch of the ulnar nerve, okay, which is what allows that muscle to participate in thumb adduction and thumb flexion. So as a result of these deep branches of the ulnar nerve being lacerated because of the superficial laceration on the medial ventral side, we know that it's the deep branches of the ulnar nerve, and as a result, this muscle, the adductor pollicis muscle, will be the one that is affected. Now, ultimately, patients with this injury are unable to hold a piece of paper between the thumb and the index finger or between adjacent fingers. So the take-home point is knowing your anatomy and knowing which nerves innervate which muscles and which ones get affected with these cuts. So yes, the median nerve is the most commonly injured in lacerations, but when it's superficial, I want you guys to start thinking about the ulnar nerve. Now let's talk about some of the incorrect answer choices. The opponent's pollicis. So that's a thumb muscle or a thenar muscle that's innervated by the recurrent branch of the median nerve and functions in opposition of the thumb. Once again, that is not what we're seeing here. That is not the injury that we have. But if you suspect this, okay, you can assess it by having a patient place the back of their hand on the table and asking them to touch the thumb to each finger, and they will not be able to do that. So once again, it's the median nerve is deep, it's in that carpal tunnel, and this superficial laceration is not going to affect it, okay? So that's answer choice E. D, your lumbricals. Well, the first and second lumbricals are innervated also by the median nerve. So once you figure out what nerve is affected, once you figure out that first step, you can rule out a lot of these answer choices. So you're going to be able to rule this one out also because it as well is innervated by the median nerve. What do the lumbricals do? Well, they serve to flex the metacarpophalangeal joints and extend the interphalangeal joints. All right. So once again, that nerve, and I keep saying it, runs deep in the carpal tunnel, not affected with a superficial lesion. Answer choice C, extensor pollicis brevis. That's located on the dorsal part of the forearm, and it functions to extend the proximal phalanx of the thumb at the carpometacarpal joint, and it's actually innervated by a nerve which everybody always forgets, and it's called the posterior interosseous nerve, which is a deep branch of the radial nerve. An injury to the radial nerve is going to present with the wrist drop. So anytime you see radial nerve, you're going to start thinking wrist drop. But once again, because they told us that this lesion was not on the dorsal part, we know that this is not the lesion that we're discussing, and this is not the muscle that will be affected. We talked about answer choice B and why that's the correct answer. Let's talk about answer choice A. The abductor pollicis brevis, that's also a thenar or a thumb muscle, and that's innervated also by the recurrent branch of the median nerve, and it functions in abduction in opposition of the thumb, okay? So once again, the clues here are to know exactly where that laceration was, keep in mind that it was superficial, and then remember which nerves provide sensation to different parts of your hand. So the ulnar nerve provides sensation over the medial 1.5 digits and a hypothenar eminence, and it has that deep motor branch that supplies most of the intrinsic muscles of the hand, including the adductor pollicis muscle. And this nerve can be damaged by superficial wrist lacerations and will present with sensory loss, ulnar claw hand, or what they call the Froment sign. The Froment sign. So great job with that question, guys. I'm going to kick it back over to Jeff.
Well, thank you, Sean. Well, that again, that's a good one, and you're gonna have to keep honing your anatomy skills. I just want to pause here and mention. We here at USMLE-Rx and our team here at RX Coach, we are here for you. We're here to help students just like you, prepare for your exams, you're preparing for the boards, and we've got a lot, a lot of experience here in helping students reach their goals. The team here, dates back 30 years. I mean, 30 years ago is when First Aid for the USMLE Step 1 was first published. And it's the spirit behind that book and that team is, students helping students. And that's really what's driving RX Coach. So when you work with our coaches, you're working with med students that have been through it. And earlier today, we actually received a note from a student that just completed or just got a score back for Step 2 CK. So while we have a lot of students that are that we're working with as they prepare for Step 1, we also have some that are also working on Step 2 CK. And he said, thank you so much again for all your help and support getting me through this insane step journey. I seriously don't know what I would have done without you. And to me, that's that's the kind of validation that really means a lot. Because it isn't just about understanding the content. We talk a lot about content here, during Question Lab, but we also want to be thinking about strategy. We want you to kind of understand the why as much as the what. And RX Coach is here to ensure that if there is a goal on your board, if there is a vision that you have of where you want to be, we can help you get there. RX Coach, what we do is, when you get signed up, we start off with a 160 question assessment. That is going to help us kind of understand your strengths and weaknesses, understand where perhaps where some of your blind spots might be, and we'll use the results of that to help develop a personalized study plan so that you can go into it knowing that your tutor has a good sense of who you are and really what you're looking for. We really want to we tailor our approach based on your needs, and we adapt based on the progress that you make. So our team of RX certified tutors has they've all gone through extensive training, and we also do. We're also kind of monitoring the progress of all of the students and working with our tutors to figure out ways that we might be able to improve the outcomes for our students. Finally, really one of our big differentiators is that the students have access to our RX 360 Plus product, which is everything here at USMLE-Rx, including RX Bricks, which we added to RX 360 Plus earlier this summer. And that's really key for us because not only can you be confident in the material that you're going to be studying from, but we also have the same level of confidence and can certainly help with remediation if and when that arises. So we definitely want you to check us out at rx-coach.com. You can go and we're going to put the link there in the chat. You can learn a little bit more about us, and if you feel like the time is now, you can set up a free consult and we can start the process. Okay. And with that, I think we can go on to the next question number 3 for this evening.
Well, Jeff, don't you feel like we're missing your athlete analogy today?
Well, this is this is the time of the year where we're it's been a weird year in terms of sports, and we know that baseball, Major League Baseball has struggled not having a bubble. NBA and the NHL, they have done well with their bubbles and getting into the playoffs. And we do feel like, it's important for you as a student to know that, coaches aren't just for students who are struggling. All of the players that you're seeing out there on the court, and we always talk about like Roger Federer and Serena Williams, but even a lot of the players that you're seeing out on the diamond or out on the court or on the ice, they have coaches and they are there to help them improve, help them to get up to that world-class level. And that's kind of that's our approach. We are going to work to take you to the level that you want to be at, and we want to make sure that you don't plateau or that you don't peak too early. We want to make sure that the plan that we devise, sets you up for success on test days. So that's what we always often talk about, having a coach that will help get you to the next level. And you need to be looking for those coaches and mentors as you go through medical school and as you work your way up the ladder.
All right. Well, thank you very much, Jeff. I feel like now we can move on. So I'll let you kick off question 3.
Let us take a look at question number 3 here. And again, we're going to start off with that lead in. Which of the following processes is most likely defective in this child's disorder? So let's read the vignette. A 2-month-old full-term boy is brought to the clinic by his parents for a well child visit. He is breastfeeding well and gaining weight adequately. He is producing the appropriate amount of wet diapers and bowel movements per day. He coos and smiles during the visit, but is unable to hold his head up. It is found upon physical examination that he has a large head with a prominent forehead, a long, narrow trunk, and short extremities, especially in the proximal segments. The growth chart shows significantly short stature for his age group. The question then, which of the following processes is most likely defective in this child's disorder? And I'll pass it over to you, Sean.
Thank you, Jeff. So once again, I want to ask you guys, how many steps do you think this question will require? I'll let you guys submit your responses in that question box along with the diagnosis if you know it. So let us know in the question box what you're thinking. So we'll give you guys a few seconds to respond. And it looks like a lot of you guys are already on the right track. But remember, this is a 2-step question. They're not asking us for the diagnosis. They're asking us for the mechanism behind the process of this condition, right? So with that, let's go ahead and uncover these answer choices and take a look and see if we can get it right. Answer choice E, secretion of osteoid by osteoblasts without a hyaline cartilage model. D, production of hyaline cartilage model. C, mineralization of cartilaginous growth plates. B, excessive resorption of cartilage. And A, defective osteoclast resorption. And I'm going to open up the poll and give you guys a few seconds to respond and let us know what you think the answer is. Once again, we want to figure out the diagnosis and then figure out afterwards what process is responsible and what process happens, what the mechanism is of that condition, so we can get to the correct answer. Now, there's one clue if they gave us in this question, you probably all would get the diagnosis right immediately. And we'll go over that clue in just a second. So we'll give you guys a few more seconds to respond. Touching base briefly on the previous question that we did, I was just got a message from Kasha where he actually sutured up a wrist laceration yesterday and used that material. So for those of you who think that, oh, anatomy is I'm done with it, you're gonna see it all of the time. So make sure you brush up on it. Give you guys a few more seconds to respond, and then we'll go over the correct and incorrect answer choices. Remember to stick around until the very, very end because we're doing a raffle, and 2 of you, lucky winners, will win access to some of our resources. All right, and give you guys a couple more seconds here to respond. Looks like we're getting a little stuck here, but we're doing okay. So let's see how we did. 42% of you guys picked answer choice C, mineralization of cartilaginous growth plates, and 22% of you guys picked D, production of hyaline cartilage models. And let's see what the correct answer is. The correct answer is D, and 22% of you guys got it right. Production of hyaline cartilage models. Okay, so well done to those of you who got it. A lot of you guys mentioned achondroplasia as you guys were submitting your responses. You're absolutely right. One thing that didn't tell us that would have probably given this giving this away to us. There's you know, we know that achondroplasia is a form of short-limbed dwarfism, right? So the key to knowing this and getting this right is knowing this process of endochondral ossification, okay, that they have as a result, short limbs, but membranous ossification is not affected. So those are two important things to keep in mind. That's what's going to help us get this right. And they gave us a lot of clues, right, to let us know that this was, in fact, achondroplasia. So we know that he has short limbs, right? We know that he has short extremities, especially in the proximal segments. He's got a prominent forehead, a long, narrow trunk, right? So we had a lot of clues, and then they just flat out told us short stature for his age group, right? So they gave us enough clues here to get to achondroplasia. And if you guys remember, please let me know, what is the inheritance pattern for achondroplasia and what gene is affected? Can you guys let me know in the question box? What is the inheritance pattern and what is the gene that is affected? And I'm asking you because it is a high yield topic. You're likely to be tested on it, because when they give you all these clues and you can find a diagnosis very easily, they can go separate ways and ask you different parts. They could ask you the inheritance pattern. They could ask you the gene involved. They could ask you about the process like they did here. So as long as you know those things, you'll be able to get whatever question the test writer throws at you right on test day, right? So let's see what you guys came up with. It looks like a lot of you guys said that it is autosomal dominant and the gene is FGFR3, and you are 100% right. It's a sporadic autosomal dominant mutation of the FGFR3 gene. So patients with achondroplasia, they're going to exhibit these symptoms, right? And these signs: short stature, which is caused by shortening of the limbs, macrocephaly with what they call frontal bossing, and mid-face hypoplasia, okay, and hyperextensibility of most of their joints. One thing to keep in mind is that the long bones of the limbs form via endochondral ossification. Now, what is that? So that is a process where mesoderm is converted to a cartilaginous model by hypertrophic chondrocytes. Bone then forms as osteoblasts. Remember, osteoblasts build. So osteoblasts secrete osteoid over the hyaline cartilage model. At the same time that these osteoblasts are secreting osteoid over the hyaline cartilage model, osteoclasts are in there resorbing the cartilaginous framework, okay? So in addition to long bones, there are other bones that also form via the same process, this process of endochondral ossification. And those bones include the sphenoid bone, the ethmoid, the incus, the stapes, the malleus, limb girdles, vertebrae, the sternum, and the ribs. So individuals affected by achondroplasia are unable to undergo endochondral ossification, particularly in the long bones, and that is why the answer choice D is the correct answer choice. So you guys have to remember that it's endochondral ossification that was affected. Now, if you picked answer choice E, you got confused and you went with intramembranous ossification, and intramembranous ossification is when osteoblasts produce an osteoid bone matrix that become osteocytes as they become trapped in the matrix that they secreted. And so woven bone, for example, is formed directly without an intermediate cartilaginous mold. So the long bones do not undergo this process. They form via endochondral ossification and not intramembranous ossification. So because we know that the long bones are defective, we know that the process that is going to be affected as a result is going to be endochondral ossification and not intramembranous ossification. We talked about answer choice D, that's the correct answer. Then we have answer choice C. So in answer choice C, we have mineralization of cartilaginous growth plates. And bone mineralization is defective in rickets when it's a child, or osteomalacia when it's in adults. And this patient does not have clinical signs of rickets. The clinical telltale sign of rickets is going to be what? Bowed legs, right? Bow legs, and bead-like costochondral junctions, okay? As well as craniotapes or a soft skull or a soft skull. And we don't see any of those symptoms here. So that's going to rule out rickets. Then it says here, excessive resorption of cartilage, and that's going to be the responsibility of osteoclasts. And osteoclasts are important for growth, remodeling, and maintaining that mineral homeostasis throughout the development of long bones. And if you have excessive osteoclast activity, okay, and that can happen in Paget disease of the bone, where mixed osteoclast and osteoblast occurs during the second stage. And in Paget's disease, you're going to present with hearing loss due to a thickened auditory foramen. And patients will often complain of an increase in hat size. So if you see increase in hat size, start thinking Paget's disease, start thinking osteoclast, okay? But this is not talking about Paget's. Here we're talking about achondroplasia. And here we're talking about, in answer choice A, defective osteoclast resorption. So if we have decreased osteoclast activity, we're going to end up having osteoporosis. And if you have osteoporosis, you're going to see things like pancytopenia or extramedullary hematopoiesis, as well as narrowed foramina. And this patient isn't showing any of those symptoms. So it's unlikely that we're going to have decreased osteoclast activity as a result of these patient symptoms, which once again are pointing to achondroplasia. So the key take-home point here is achondroplasia is due to defective chondrocyte activity during the process of endochondral bone formation or endochondral ossification. Okay, so keep that in mind. Great job, guys. I'll turn it back over to Jeff.
Yeah, definitely good work, everyone. And we are going to work to close strong. Question number 4 tonight. And we will jump again, go to the lead in. And it is intake of which of the following should be limited as part of the management of this patient's condition. Okay, some keywords there. So let's read the vignette. A 31-year-old man presents to his primary care physician because of progressive pain and stiffening of his shoulder. He says that over the past 2 years, he has noticed increasing difficulty throwing a baseball while playing in a local recreational league. His medical history is notable for chronic lower back and right shoulder pain. He has no urinary or bowel incontinence. His pulse is 72, respiratory rate is 18, and blood pressure is 138/84. On exam, he has brownish gray pigmentation of his sclerae and ear pinny. There is no joint warmth or erythema, but he does have stiffness and limited range of motion of his shoulders and lumbar spine. A systolic heart murmur is heard in the second right intercostal space. So, intake of which of the following should be limited as part of the management of this patient's condition? Sean, take it away.
Excellent. Thank you very much, Jeff. So I already see that Shaw here is on the right track. So well done to you for getting the diagnosis. So in this situation, we need to figure out what's going on and then what we can limit to help this patient feel better. So with that process in mind, I'm going to uncover these answer choices and let you pick an answer. E, tyrosine. D, triglycerides. C, leucine. B, homocysteine. And A, cysteine. So we'll give you guys a second here to submit your responses and let us know what you think the correct answer is. So we'll give you guys a few seconds to submit your responses and let us know. Looks like the answers are starting to come in. We'll give you guys a few more seconds to respond here. The choices are cysteine, homocysteine, leucine, triglycerides, and tyrosine. Some things which you probably haven't reviewed in a while also, but they're important, and we're going to go over them here in just a moment. You guys seem to have the diagnosis right, so we just need to go one more step to figure out what we can do to manage this patient's condition. So almost on the right track, but let's get you there all the way. We'll give you guys a few more seconds to respond, and then we'll go over the correct and incorrect answer choices. Excellent. Looks like you guys have submitted your responses. Let's see how you guys did. Looks like 34% of you guys picked homocysteine, and in second place, with 29% of you guys picking the answer, was tyrosine. So homocysteine and tyrosine were the top two. Let's see what the correct answer is, and the correct answer is E, tyrosine, and 29% of you guys got it right. So great job to those of you who got it. If you didn't, don't worry, we're gonna go over it now. So we're talking here about alkaptonuria, and you guys seem to get that right. So great job. It's a congenital deficiency of homogenetic oxidase, okay, which is important in the degradative pathway of tyrosine to fumarate. It's autosomal recessive, and we see lots of findings which they actually told us about: blue-black connective tissue, ear cartilage, and sclera. And urine turns black on prolonged exposure to air. Now, they didn't give us that clue, but if they did that, it would have just been much too easy, right? It would have been much too easy. So let's take a look at the clues that they did give us. Well, they told us about the brownish gray pigment of the sclera and ear, okay? And they told us about stiffness and limited range of motion. And they also told us about a systolic heart murmur in the second right intercostal space. And if you look here, one of the things you will see in people, in patients with alkaptonuria, is going to be this heart murmur. Can you guys tell me what heart murmur we are referring to? I'll give you guys a couple seconds to respond and let us know in the question box. What is the heart murmur, a systolic heart murmur, in the second right intercostal space? Looks like a lot of you guys are saying aortic stenosis. So let's go over these. Let's talk about why tyrosine is correct and why the other ones are incorrect. So this patient presents with early onset joint pain and stiffening, skin hyperpigmentation, and limited range of motion of the large joints, and a systolic murmur in the aortic area. So as a result, we put those things together, it paints the picture of alkaptonuria, which we talked about is an autosomal recessive disorder. Now, if they told us that the patient had black urine or black diapers, we would have gotten to that answer choice right away and much more quickly, but they're not gonna make it that easy for us. Remember though, that the first clinical manifestation of alkaptonuria may occur in infancy as excess homogenetic acid is excreted in the urine, and that will impart a black color to the urine when it's oxidized, and it may even cause black staining of diapers. So when you see black urine, black staining of diapers, immediately go to this answer choice, okay? Well done. So now, patients who have this condition are usually free of symptoms until middle adulthood, when they experience this blue-black discoloration of the sclera, which is the most common, axillary skin, tympanic eardrum, genital skin, nail beds, and the face. Now, this discoloration is a result of dermal deposits of pigments, okay? So in situations like this, we want to limit dietary tyrosine or L-phenylalanine to help prevent the progression of this arthropathy. And that's because of this enzyme, okay, homogenetic acid oxidase, which results in an accumulation of homogenetic acid. And that, as you guys may remember, is the intermediate product in the metabolism of phenylalanine and tyrosine. And so it cannot be further metabolized without functional homogenetic acid oxidase. So if we don't give them tyrosine, we can help manage their condition, okay? So that's answer choice E, and why answer choice E is correct. Answer choice D, triglycerides. Well, triglycerides, that's, if you have too much of that, we call that dyslipidemia, and we wanna, have all of our patients avoid too many triglycerides, right? But patients with dyslipidemia will have abnormal cholesterol levels, increased LDL levels, and this patient, they didn't tell us about any risk factors related to dyslipidemia. So the results of that lipid panel are not even provided, so we can pretty confidently say that that's not what they're looking for here. Leucine, Leucine restriction is part of the management of maple syrup urine disease. And that occurs because you can't degrade these branched chain amino acids, including leucine. So with maple syrup urine disease, the patients are typically identified through newborn screening. And if it's untreated, they'll likely present in infancy with a metabolic decompensation manifested normally as altered mental status, irritability, lethargy, and vomiting. One of the things about maple syrup urine disease to keep in mind is that the urine may have a sweet maple syrup odor. So once again, not consistent with this patient's findings. So answer choice C, leucine, is incorrect. So now we have homocysteine. Homocysteine increase, and that's going to be seen in homocystinuria, which is also an autosomal recessive disease. And homocystinuria is caused by multiple enzyme deficiencies. Most commonly, it's going to be cystathione beta synthase, which will result in symptoms like a marfanoid habitus, optic lens dislocation, osteoporosis, as well as cardiovascular complications. So you guys may have seen a cardiovascular complication and started thinking about homocystinuria, but once again, they didn't paint that picture with the constellation of symptoms, so we can rule out answer choice B. Cysteine, well, that's going to be elevated in patients with cystinuria, which is also autosomal recessive, and that'll cause nephrolithiasis and what they refer to as staghorn calculi. You're also very unlikely to see skin and joint manifestations. So this patient does not have any urinary symptoms or any back pain suggestive of stones. So we can use that to rule out answer choice A, which is cysteine. So